Welcome to the final week of this course, Economic Evaluation in Global Health, and this week we're going to discuss some special topics of interest to me and to many other analysts in the field of global health economics. This final week, we're going to discuss the role and value of vaccines, which are some of the most cost-effective healthcare interventions, not just in global health, but in healthcare in general. In the second part, we're going to discuss special features of health economic evaluation as used in low-income settings. And a lot of global health work is performed in low-income settings, but also in middle-income settings, so in low and middle-income countries. And in the final part, we'll look at the Consolidated Health Economic Evaluation Reporting Standards, or CHEERS. And CHEERS is a series of recommendations for people who are writing economic evaluation papers to enable comparability of different papers and to standardize the quality of reporting health economic evaluations. And I think that understanding CHEERS is important to being able to do a good job assessing the quality of economic evaluation publications and reports when you come across them in the literature. Like I said, vaccination is one of those highly cost-effective interventions, and not just in low-income countries, but also in high-income countries. And some vaccines have been available for many, many years, like BCG for tuberculosis and the measles vaccine, but some are more recent, have been developed more recently, like the vaccine against the human papillomavirus, which is a main or major cause of cervical cancer around the world. One of the most common, if not the most common, cancer in females globally. And another one is the rotavirus vaccine. And rotavirus is responsible for a large proportion of the diarrheas that occur in children in many parts of the world and lead to a large number of lives lost and disability-adjusted life years. So vaccination is really important, not just historically, but also in contemporary times. In fact, in recent weeks, I've heard of the development of an oral cholera vaccine. And as you know, cholera breaks out periodically in places where there's instability and conflict or natural disasters. So such a vaccine would lead to the averting of many deaths and the saving of many lives. Like I said, vaccination is one of the main reasons for the remarkable improvements in health and life expectancy over the last 100 years, and it's considered one of the greatest public health achievements in the 21st century. Every year you have some 100 million children being vaccinated, and these vaccinations lead to the saving of some 2.5 million deaths. But still massive gaps exist, and many children on an annual basis in poor countries miss out on routine vaccines, the traditional EPI vaccines. And even more children miss the newer, more expensive vaccines like HPV and Rota I talked about in the last slide, but also others like Haemophilus and the pneumococcal vaccine. So still access gaps exist. And in fact, it's been demonstrated that, in the last few years, some countries have made steps backwards. So some countries which had achieved high coverage for things like DPT and the measles vaccine are actually registering reductions in what we call vaccine coverage. So it's not to say that vaccination is cheap, and to be able to meet the demand for all vaccines, the old and the new, would be a costly enterprise, between $50 to $60 billion between 2011 and 2020. But this would lead to substantial benefits. So the question to governments is, should they allocate money to vaccines, especially the new ones like HPV and pneumococcal? Should they be allocating scarce governmental resources to these vaccines? Because you have the promise of benefit, but at a given potentially high cost. And really, this is the question that we've been asking throughout this course in the last 10 weeks. What is the value of an intervention, a healthcare intervention? And even for vaccination, which we know is a good thing traditionally, policymakers and governments have to make these kinds of hard decisions. As I said in the previous slides, the newer vaccines are much more costly than the older ones, and this is because of patent protection of new technologies like recombination and the use of carrier proteins and adjuvants. And we've been saying over the course that new drugs carry a premium on innovation, and so you expect new interventions to be more costly than old ones. The other reason is that there is increasing regulatory oversight. It's not easy to get a drug through the regulatory process. So as an example, look at this data. The DPT vaccine was discovered in the 40s, and it costs $21 in the US for a dose. Pneumococcal, which is more recent, in 2000 costs $120. And the HPV vaccine, which is only recently, less than 10 years ago, discovered less than 10 years ago, costs nearly $130. So as you can see, there is an increase in price, as the year of discovery of the vaccine gets more recent, essentially. So then the question to policymakers is, should they pay for the new expensive vaccines? Essentially, should they add them to their EPI programs and increase the number of vaccine-preventable diseases that they attempt to protect against? And this question is more relevant in poor countries. And the reason for that is extreme budget constraints. So this is where economic evaluations come in. Economic evaluations, they help us, or they help governments to make these kinds of decisions. And some countries use them, like the US Advisory Committee on Immunization Practices takes into consideration economic evidence to make vaccine-related policy decisions. And in the UK, the National Institute of Health and Clinical Excellence, also called NICE, does the same thing. And there are other agencies like IQWiG in Germany and PBSE in Australia. And the Gavi Alliance, which is one of the most influential financiers of vaccination in poor countries, also may take into consideration economics evidence. And sometimes individual governments also use economic evidence to decide whether they should pay for a new vaccine or expand their EPI programs. My discussion today of vaccination draws on the work of a Harvard professor called Till Barninghausen. And he wrote this paper in 2012 about how there are different approaches to economic evaluation conceptually and in practice. And he says that most economic evaluations of vaccination, and actually in healthcare in general, a lot of the stuff we've been talking about usually adopts a narrow perspective, and it incorporates benefits that are linked to the healthcare sector. So healthcare gains and averted medical spending. Essentially, DALYs, QALYs, life years, closely related to healthcare. But his proposed framework considers two important aspects of economic evaluation of vaccines. It includes the breadth of the analysis and the measurement of benefits that are accounted for in the analysis. So it tries to expand the framework as it applies for economic evaluation as it applies to vaccination. So he talks about the broader impact of vaccination on economic development in these 4 dimensions. The first one is that if you have people who are healthier, they are physically stronger and they can work better, they can work for longer and harder. The other one is that healthy children are able to finish school and they can achieve better educational outcomes. And if you achieve better educational outcomes, you're more likely to contribute to the economy because you can do complex tasks more efficiently. The third one is to lower child mortality and increase life expectancy. And when you do that, families tend to invest more in children's education when children survive. And this also improves economic productivity when the children finally enter the labor market. And the other one is to do with foreign direct investment. If you have a productive workforce, a healthy and productive workforce, then people bring in money and invest in physical capital and infrastructure, and they introduce technology that leads to enhanced economic productivity. So this expanded framework of benefits that accrue from vaccination can be looked at in 5 different dimensions. The first one is what we call outcome-related productivity gains, and we talked about them in the previous slide. They increase productivity because vaccines improve physical and mental health. The second one is to do with behavior-related productivity gains. The idea that mobility and mortality benefits that accrue from vaccination lead families to change their behavior. So, for example, they reduce fertility, having less children because the children that you vaccinated survived. And this can have an impact on the economy. Healthier children, fewer children, and healthier adults who participate in the economy. And you can even expand this further in demography to the demographic dividend, what they call the demographic dividend, and you can look it up if you're interested. So that's behavior-related productivity gains. And then there's the idea of externalities in economics, both to do with herd immunity, the idea that if you vaccinate a certain proportion of the community, the ones who are not vaccinated get benefits. That's called an externality. And also reduced antibiotic resistance because you reduce the community load of potential pathogens because children are immune to the pathogens. And then there are community economic externalities. A country which performs better in a macroeconomic dimension has better social and political stability. Then the other one is risk reduction, the welfare gains that come because future outcomes uncertainty is reduced. So you know that children are going to survive longer, and that's a fact based on having been vaccinated. And then there are just other utility gains of health and survival that are beyond economics, that are beyond just expanding the economy and making a society richer. So as you can see, this expanded framework goes beyond just counting DALYs and QALYs and life years and tries to look at the broader benefits of vaccination. So let's take an example and apply the broadened framework to the recently discovered and approved human papillomavirus, and by recently I mean less than 10 years ago in 2006. So HPV is a sexually transmitted infection which affects both men and women. It has these high-risk oncogenic types that cause cancer, particularly cancer of the cervix, but also cancer of the anus and some other cancers. And then there are the low-risk types which cause genital warts and other diseases like respiratory papillomatosis. So in 2006, GSK produced a vaccine called Cervarix, which is bivalent, and then in the same year, Merck and company produced Gardasil, which is quadrivalent, which is essentially a 4-valent vaccine. And this one protects against 6, 11, 16, and 18, and the bivalent was only 16 and 18. And they were initially approved for just 16 and 18, which are high-risk types that cause cancer. But now, Gardasil is also approved for prevention of genital what? And the other cancers, like anal, vaginal, and the cancer of the vulva. So this is a background on the HPV vaccine. So looking at the virus itself, HPV is a family of the DNA type viruses, and it has many subtypes, over 100. And it has a global prevalence, essentially, happens in almost every country in the world. And the oncogenic ones are all these listed here, and then there are the non-oncogenic ones, which cause warts and papillomatosis. And these ones cause this wide range of cancers, including oral, oropharyngeal, and then the anal and genital cancers. Another slide to demonstrate that the poor countries, here called developing countries, although I prefer the term low-income countries, bear the brunt of HPV and also HPV-related cancer, HPV-related cancers. And the problem is that most don't vaccinate against it. So there's a gap in vaccination for HPV. And you will see that in developed countries you have under 100,000 cancers of the cervix, and in the poor countries you have nearly 1 million of them. And in these columns you can see the proportion that is attributable to the HPV virus, and you'll see it's a substantial proportion of the total number of cancers. So low-income countries or poor countries bear the brunt not just of HPV, but HPV-related cancers, and the problem is that most don't vaccinate against it. So let's look at the outcome-related productivity gains associated with vaccination against HPV in poor countries. We know that based on epidemiology data, diseases like cervical cancer affect the most productive women in society, who are young mothers, and when that happens, they have to withdraw from the labor force, and this reduces productivity both at the household and the national level, and eventually they cause premature mortality, which is also a cause of lost productivity. Premature mortality also causes lost productivity. Even in the US, so for 2003 data for anal cancer, it shows that men and women lose some 20 years of productive life, and this is for each anal cancer related death. And the deaths lead to a loss of between $350,000 to $600,000 US. So a high cost, opportunity cost of getting these vaccine preventable cancers. And this demonstrates that vaccination against HPV would lead to outcome-related productivity gains. This slide is just to reinforce a point I made in the previous slide, that cervical cancer affects women who are in their productive years, and the productivity is not just associated with participating in the labor force, but also things like childcare. So in this curve, which comes from the Congo, you see that the red curve, this curve, which is the economic activity by age, this is the age axis here, you see economic activity is correlated with incidence of breast cancer, this blue line, and not breast cancer, sorry, cervical cancer, and cervical cancer mortality. So you can see they peak nearly the same time around here. And so the impact of HPV vaccination on outcome-related productivity gains is substantial because of this correlation between productivity and death and illness from cervical cancer. The other dimension of vaccination benefits is to do with behavior, and in households where patients get cancer, they reduce daily food intake, for example, and they also report that there's some education-related impacts. So children with parents who have cervical cancer or other cancers may be absent from school. And because of the costs of healthcare, they may have difficulty paying for school. And we know that these kinds of health-related issues, which may be to do with this loss of food and losses in education, have an impact. They diminish productivity and earnings when these children grow up. So preventing HPV and therefore preventing cancers would have this behavior-related productivity benefit. And that's why vaccination against HPV is important. Of course, there might be some negative impacts on behavior as well, and some people have suggested that if you vaccinate against HPV, it might lead people to engage in high-risk behaviors, thinking they're not at risk, and that this might have negative impacts on community health. But there's no evidence to suggest that this is the case in communities where they have introduced the HPV vaccine. In the dimension of externalities, given the sexually transmitted nature of HPV, you expect herd immunity effects, and they are realized in theory in two ways. If you vaccinate both males and females, it confers protection against unvaccinated sexual partners, both for the males and the females. Now, if you vaccinate only females, then it reduces transmission to their unvaccinated male partners, and this reduces onward transmission to the female partners of the original male partners. So there's a community benefit there expressed as an externality. And mathematical models have predicted that, and data from Australia suggests that there's a 44% decline in male genital warts as a result of female HPV vaccination, which confirms the presence of these herd immunity effects, which are externalities, the benefits of the externalities associated with vaccination against HPV. So obviously there's the other more traditional benefit of HPV vaccination. And as you can see, for example, in the US, the prevention of HPV-related diseases through vaccination would avert a substantial amount of economic costs. So depending on the cancer, you have many millions of dollars. Cervical, $150 million, $60 million for anal, $150 million for oropharyngeal, and $5 million for penile, and 8 for vaginal, and 21 for cancer of the vulva. So it's important that economic evaluations of vaccination account for not just the clinical benefits, but also the economic benefits and the other benefits, as we've discussed in the previous few slides. So as a conclusion, the old economic evaluations of vaccination focused on a narrow set of benefits that were closely related to health outcomes. As an example, they measured DALYs maybe and QALYs. But the point is that these underestimate the value of vaccination. So the new ones in contemporary times should include the outcome-related productivity gains, the behavior-related productivity gains, and the externalities. And we saw an example using HPV, going through these different dimensions of vaccine-related benefits. And we also made a point in the previous slide that people should include multiple distinct disease areas when preventing a certain antigen or a certain disease using vaccination leads to the prevention of multiple diseases, as is the case for HPV. And the broader approach to economic evaluation would improve decisions made by policymakers with regard to vaccination. So with that, I would like to end the first part of week one, and I hope that at least I convinced you that vaccines are not just important, but that an approach to evaluating their economic efficiency or cost effectiveness should include a broader set of outcomes than we traditionally measure in cost effectiveness analysis or in traditional economic evaluations. Next week, not next week, but in the next video, in the second video of week 10, this last week, we're going to look at the special features of economic evaluation and the use of health economic evidence in poor countries or low-income countries. Thank you very much for your attention, and see you in the second video of week 10.